The most common benign mass of the kidneys are the hamartomas. And we are now going to describe unilateral and bilateral hamartomatosis of the kidney. But what is a hamartoma? It is a benign tumor or tumor-like lesion composed of tissue which is normally present in any organ, but abnormal in quantity, arrangement, or degree of maturation. And this term was coined by Albrecht in 1904. The most common hamartomas of the human body are the nevi, and in the kidney, the most common hamartoma is the angiomyolipoma. Histologically, the angiomyolipoma is composed of three components. The angio, which is excessive number of vessels, the myo, which is a proliferation of smooth muscles that arise from the wall of the venules and arterioles, and lipoma, which is excessive accumulation of fat. The fascinating aspect about angiomyolipoma is that some of these components may predominate or may be almost exclusively present. For example, there may be only vascular proliferation in the kidney, like a hemangioma. There may be only fat, and that will be like a lipoma of the kidney. Or there may be only smooth muscles, like in the leiomyomas of the kidney or the myomatous form of angiomyolipoma. And depending on the tissue that predominates, there will be a variety of radiographic manifestations, not only by standard radiography, but also by ultrasound, by CT, MRI, and by angiography. Another fascinating aspect of the angiomyolipoma of the kidney is that not uncommon is an infiltrating lesion. And because it can extend beyond the capsule of the kidney at the surgery and on gross inspection, it can mimic a cancer of the kidney, particularly the hypervascular form of angiomyolipoma. Many years ago, we published what I consider the pathognomonic angiographic sign of hamartomas, which are the macroaneurysms of the interlobar renal arteries. In other words, these are aneurysms that arise from large size branches of the renal artery. And this makes it different from the aneurysms that arise from smaller vessels seen in polyarteritis nodosa and in the necrotizing angeitis. In the latter, we see areas of ischemia, while in angiomyolipomas, the aneurysms are not associated with ischemic changes. The hypervascularity of the angiomyolipoma in the parenchymal phase of an angiographic study may mimic a cancer. However, we do not see arteriovenous communications in angiomyolipoma, nor do we see obstruction of the veins, findings that are common in cancers of the kidney. This is a unique cast corrosion preparation. To me, is the only one ever made of an angiomyolipoma, which shows the hypervascularity of the angiomyolipoma. And on close inspection, one can see the tortuosity of the intrarenal arteries and the macroaneurysms. In these casts of renal arteries, the macroaneurysms are apparent. And to me, this is the pathognomonic sign of an angiomyolipoma. On gross examination of a renal angiomyolipoma, the appearance of the lesion depends upon the predominant cell type. They may appear as a yellow, gray, or yellow-gray mixture, according to the proportion of fat to spindle cells. The mass may present an angiomatous appearance. Hemorrhage and necrosis may be present, and gross differentiation from a hypernephroma or renal cell carcinoma may be impossible. Some surgeons have removed angiomyolipoma in the assumption that the patient had a renal cell carcinoma. because on gross examination, the two lesions may be morphologically identical. This is a gross specimen of an angiomyolipoma of the upper pole of the right kidney. Note the hemorrhagic appearance and note that the lesion extended beyond the renal capsule. Impossible to rule out the renal cancer. This is an angiomyolipoma of the lower pole of the left kidney. Note the myomatous elements that produce a reddish but not hemorrhagic appearance. This is because the myomatous element predominated in this lesion. This is an angiomyolipoma of the lower pole of the right kidney where the fatty elements predominated and it was initially classified as a lipoma. 50% of renal angiomyolipomas occur in patients with tuberous sclerosis. 80% of patients with tuberous sclerosis have renal angiomyolipoma, being the most common visceral hamartoma in this condition. In non-tuberous sclerosis patients, renal involvement is usually unilateral and solitary, although we have seen focal angiomyolipomas affecting the two kidneys without evidence of tuberous sclerosis. Women are affected more common than men. About 80% of renal angiomyolipomas have been described in women, and more commonly manifested between the third and sixth decade. Symptomatic renal angiomyolipomas has been reported as occurring in 16% of patients, and usually is due to hemorrhage into or around the tumor. This may cause pain, which is usually in the flank, hypotension and shock, an enlarging mass, gastrointestinal symptoms, hematuria, a palpable mass, and fever. The kidneys of patients with renal angiomyolipomas may be normal in size or be enlarged, and the enlargement can be symmetrical or asymmetrical. The lesion may appear lucent, and this will be almost the pathognomonic sign of angiomyolipomas. The pelvocalceal system may be distorted in a focal fashion or diffuse, although in some instances with bilateral renal angiomyolipomas, there may be no morphological changes affecting the pelvocalceal system. Some renal angiomyolipomas may be completely avascular and therefore resemble a renal cyst and a vascular metastasis or necrotic carcinomas. There may be minimal hypervascularity, and this pattern may mimic a Wilms tumor, particularly in infants, a lymphoma, or a poorly vascularized renal cell carcinoma. The hypervascular tumor may resemble a renal carcinoma, and angiomyolipoma should be suggested if there is the presence of these outpouchings of the renal arteries, that is the macroaneurysms of the interlobar renal arteries. There may be no evidence of venous obstruction, which is common in cancer, or venous collateral circulation, and the onion peel appearance seen during the venous phase has been described as characteristic by Dr. Kilnani. This woman had an enlarged right kidney, and the upper aspect of the kidney was lucent. However, the lucency was misinterpreted as representing bowel content. At urography, a large mass distorting the upper portion of the right kidney and producing a vertical axis of the right kidney was observed. Note the lucency that is observed in the upper portion of the right kidney. When contrast is injected, it is not possible by urography to recognize the presence of fat. The fat should be diagnosed before injecting contrast material. Echographically, the abundance of fat produces an enlarged mass with speckled echogenicity. This mass is recognized as fat by the CT examination of the left kidney. In this patient with an angiomyolipoma of the left kidney, note the lucency in the central portion of the left kidney that was typical of fat. MR findings are pathognomonic of fat by observing the high signal at the level of fat, as demonstrated in the right kidney of this patient. At angiography, we may observe a hypervascular mass as seen in these 4 images. Note that the bottom images were obtained following the injection of epinephrine. When injecting epinephrine or angiotensin, we may observe that the vessels of the angiomyolipoma may remain patent. This does not mean that the patient has a renal cancer, so a false positive epinephrine test may be observed with renal angiomyolipoma. This is the same patient after injecting contrast in the renal artery. Note the hypervascularity and observe that in the medial upper portion of the right kidney, the lesion is infiltrating the perirenal tissue. In this phase, it will be very difficult to recognize that this is not a cancer, but an angiomyolipoma. However, on close scrutiny, we can see some outpouchings of the renal arteries that are the pathognomonic sign of angiomyolipomas we described many years ago. In this patient, an angiomyolipoma of the upper portion of the left kidney produced a mass and distorted the left pelvocalyceal system. There was some lucency within the mass. An angiogram of the left kidney shows the hypervascularity, the extension of the tumor beyond the renal capsule, and note also focal outpouchings, the pathognomonic sign of angiomyolipoma. This patient had an abdominal mass. Selective right renal arteriogram revealed hypervascularity in the lower half of the right kidney and macroaneurysms that are best seen in the lower pole. This is another phase of the angiographic examination of the previous patient, showing the hypervascularity around the lower pole of the right kidney, lateral to it and medial to the right kidney. At surgery, this patient had extensive angiomyolipomatosis of the retroperitoneum and of the mesentery. This is the largest angiomyolipoma that we have ever studied. This is another case with an angiomyolipoma of the upper pole of the right kidney. Note that we do not see significant neovascularity, but we see the pathognomonic angiographic sign, which is the presence of macroaneurysms in arteries of the upper pole of the right kidney. The next 3 images correspond to an angiomyolipoma of the right kidney. Note that the lesion is hypovascular, and note that it is also infiltrating. It will be very difficult to rule out an inflammatory or a neoplastic process because there is nothing characteristic in the findings to suggest an angiomyolipoma. These are 2 patients. The one on top represents a focal lesion in the lower pole of the right kidney, as I will show you later, and the one below a lipomatous form of angiomyolipoma of the lower pole of the left kidney. In both instances, there were no neovascularity observed, and the fatty component of the angiomyolipoma is detectable by sonography, CT, or MRI. Here is a fatty angiomyolipoma, the lower pole of the right kidney. It can look like a cyst or a large necrotic carcinoma of the lower pole of the right kidney. The presence of fat is best observed on sonography, CT, and MRI. We mentioned that in tuberous sclerosis, the renal angiomyolipomas are most often bilateral, and we're going to briefly discuss this entity. Genetically, it is an autosomal dominant condition with new mutations. The chromosome 9 and 11 are involved, and there is no DNA marker. There are abnormalities in cell differentiation that can be seen particularly in the skin, nervous system, and viscera. And the viscera most commonly involved is the kidney. But we can also see changes in the lungs and in the heart. The incidence is 1 per 10,000 to 500,000 people. The prevalence at birth is 1 case in 12,000 infants, and there is no sexual or racial predilection. The clinical findings are adenoma sebaceous, seen in 80% of patients, and they occur on the face. However, they are neither adenoma nor do they arise from the sebaceous glands. They are angiofibromas of the skin. So the terminology of adenoma sebaceous is a misnomer. The subungual fibroma is considered the pathognomonic clinical sign of tuberous sclerosis. It is seen in the handnails or in the toenails. Shagreen patches, which is thickened patches of skin in the lumbosacral area, can be observed. Port wine angiomas, café au lait spots, as one may see with other conditions such as neurofibromatosis or Albright's syndrome. The presence of fibroepithelial tags and yellow plaques in the retina that are called phacomas, and they represent the proliferation of glial tissue in the retina of the eye, seen in 60% of patients. Complication of patient with tuberous sclerosis consist of seizures and mental retardation, obstructive hydrocephalus. There may be pneumothorax or chylothorax. High blood pressure and renal failure may also be encountered. These are 4 patients with tuberous sclerosis. Note the first patient had mental retardation and she also had seizures. Note the extensive angiofibromas of the face. The second patient is a Vietnamese girl with tuberous sclerosis. And the third patient is a Caucasian with tuberous sclerosis. The last one had also tuberous sclerosis, and the angiofibromas of the skin only occurred around the nose. These are café au lait spots in the thigh of one of our patients. Clinically, this patient had all the stigmata of tuberous sclerosis, and the urologist thought that the patient had polycystic disease of the kidney, when actually the patient had bilateral renal angiomyolipomas, and on clinical examination there were angiofibromas of the face, café au lait spots, subungual fibromas, as well as phacomas of the retina. This is a yellow plaque on fundoscopic examination, which represents a phacoma of the retina. The diagnostic features of tuberous sclerosis will be briefly discussed. The central nervous system is involved with cortical tubers, subependymal nodules. Giant cell astrocytoma may be also observed, and radiographically some of these tubers calcify and appear as periventricular calcification, with the differential diagnosis of cytomegalic inclusion disease as well as toxoplasmosis. That would enter in the differential diagnosis. The lesions of the skin we previously discussed, and they consist of facial angiofibromas, subungual fibroma, and fibrous forehead plaques. In the retina, the hamartoma is characterized by a yellow plaque, so-called phacomas of the retina. The kidneys have multiple angiomyolipomas. There can be rhabdomyomas of the heart, hamartomas of the lung, the rectum, the teeth, the gingiva, the adrenal gland, the gonads, the liver, the thyroid, and the bones will be involved, as I will show you later. In the brain, one may observe in the frontal lobes cortical tubers within the cortical gyri with variable extension to adjacent white matter. MR is more sensitive than CT, for the detection of cortical tumors, and plain radiography may reveal the intracerebral calcifications. White matter tumors are seen in the frontal lobes as islets of abnormal heterotopic giant cells in a radial pattern, easily identified on MR. Subependymal nodules are observed in the thalamus or caudate nucleus and project into lateral ventricles. Candle guttering has been described, and CT is more sensitive than MR in demonstrating the intracranial calcifications that present as subependymal nodules. Subependymal glial giant cell astrocytomas are seen around the foramen magnum. They are usually a slow growth, and MR is the procedure of choice using gadolinium to enhance the lesion. Other rhabdomyomas that are seen in tuberous sclerosis include the rhabdomyomas of the heart that are detected by echocardiography. We can see them in magnetic resonance imaging, and usually are the cause of left ventricular enlargement in patients with tuberous sclerosis. They often regress. In the lungs, one may see a reticular pattern that is quite similar to that observed in patients with progressive systemic sclerosis, including individuals with DIP, the squamous interstitial pneumonitis, because they tend to have a predominant basilar distribution. The reticular pattern is best analyzed on CT examination of the chest. In the bones, we may see sclerotic patches or nodules. The bone nodules, which represent multiple bone islands, can mimic osteoblastic metastasis. And the bone abnormalities are typically seen in the pelvis, lumbar spine, in the cranial vault, in the metatarsals and metacarpals, as well as in the phalanges. In the liver, there may be hamartomas, and they are detected by CT, MRI, or ultrasound, and also angiography can be utilized to detect the hepatic hamartoma. This is a patient with bilateral renal angiomyolipomas, which enlarge the kidneys but do not distort the pelvocalcial system. With bilateral nephromegaly, we have to rule out bilateral renal vein thrombosis, infiltrating lesions of the kidney like lymphoma, amyloidosis, and certainly this patient does not have obstructive uropathy. But note that in the ileum, we can see patchy sclerosis, and that will be a clue to the diagnosis of bilateral renal angiomyolipoma. This is my first case of angiomyolipoma studied several decades ago of a lady who was operated in Texas, and they made the erroneous diagnosis of polycystic disease. She presented with renal failure and hypertension, which are features also observed with the polycystic disease. Note the picture to your left, a urogram where we can see poor excretion of the contrast material and marked distortion of the pelvocalcial system. It almost looks like bilateral hydronephrosis. This lady had nodular densities in the ileum, which are the multiple bone islands of the hamartomas of bone seen in tuberous sclerosis. A bilateral retrograde pyelogram revealed that there was no obstruction of the ureter and marked the dilation and distortion of the pelvocalcial system bilaterally. Again, clinically, they suspected polycystic disease. Selective right renal angiography revealed the hypervascularity of the hamartomas of the right kidney with the macroaneurysms of the interlobar renal arteries. This is the first encounter with angiomyolipomas that exhibited aneurysms, and we described that as the pathognomonic sign of tuberous sclerosis. Note in the parenchymal phase the heterogeneous hypervascularity, which in this phase would make the lesion indistinguishable from a hypervascular renal cell carcinoma. This is a coronal MRI of the retroperitoneum showing the bilaterally enlarged, distorted kidneys with the bright signal of fat in bilateral angiomyolipomas of a patient who had tuberous sclerosis. This is a CT study of a patient with tuberous sclerosis, and note the punctate calcification, particularly in the subependymal region, which represent the hamartomas due to calcified glial tissue of a patient with tuberous sclerosis. Retinal calcification can calcify, as noted in this CT examination. This is a chest rentgenogram which reveals enlargement of the heart due to rhabdomyomas of the left ventricle, a reticular pattern in the lower zones due to the hamartomatosis of the lungs, an elevated right dome of the diaphragm, which was caused by an enlarged liver, which had also hamartomas. This patient had a bilateral reticular pattern in the lungs and developed a spontaneous pneumothoraces. This radiographic pattern is similar to what one may see with conditions that produce a diffuse reticular pattern, such as scleroderma, sarcoidosis, end-stage fibrosing alveolitis, etc. Cystic areas in the short tubular bones with sclerosis that can be nodular or irregular cortical thickening are findings of tuberous sclerosis in the long bones. These are 4 images of a patient with tuberous sclerosis. Note that there is some sclerosis of phalanges, cortical thickening, and discrete cystic areas. Renal vein thrombosis was first described by Rayer in 1873. Kaufman collected 96 cases occurring in childhood since the year 1900. McFarland in 1965 described 36 patients. Beck and Marshall in 1968 reviewed 40 patients in whom a diagnosis had been made during life. McDonald described 24 patients in 1974. And in the last 20 years, sonography, computed tomography, magnetic resonance imaging, and angiographic examinations have demonstrated the ability of these non-invasive and imaging techniques in demonstrating the presence of renal vein thrombosis. There are many causes of renal vein thrombosis. Malignancies in adults should always be kept in mind, and they can be due to a hypernephroma or renal cell carcinoma. Carcinoma of the pancreas, particularly the left kidney, can cause invasion of the left renal vein and be the cause of a left renal vein thrombosis. A retroperitoneal malignancy, metastatic disease to retroperitoneal nodes with secondary invasion of the veins. All of these are possibilities. In children, we shall discuss later, particularly severe dehydration, babies from diabetic mothers, babies with diarrhea, the 3 Ds, dehydration, diabetes, and diarrhea. Inferior vena cava thrombosis propagating into the renal veins is not uncommon, particularly when there is a thrombophlebitis of the pelvic veins or the veins of the lower extremities. Polyarteritis nodosa can cause renal vein thrombosis. Heart failure, injuries to the abdomen, or surgical trauma to the retroperitoneum, and interestingly, medical nephropathies, such as membranous glomerulonephritis, perinephritis, papillary necrosis, and amyloidosis. High probability situations for renal vein thrombosis include the presence of a renal cancer, abdominal trauma, membranous glomerulonephritis, or other nephropathies in patients who have unexplained decreased renal function, acute idiopathic non-obstructive renal failure, and renal allografts with unexplained deterioration of transplant function. The morphological staging of renal vein thrombosis, correlating rate and type of occlusion with development of collateral venous drainage and renal response, is as follows. The renal vein thrombosis can be acute or chronic. When we say chronic, we mean gradual. The acute form is complete or incomplete. And if there is an acute complete obstruction, we have to expect edema of the kidney, that is a marked congestion. And the marked congestion is manifested by a lack of function, be that adult or a child. with a swollen kidney that does not excrete contrast, and with a non-dilated pelvic-calyceal system is almost pathognomonic of renal vein thrombosis. This marked congestion can rupture the kidney and lead to retroperitoneal hemorrhage or lead to hemorrhagic infarction, and the late sequela is atrophy of the involved portion of the kidney. Incomplete acute obstructions lead to mild congestion, and this results also in poor function. The mild congestion can be seen accompanied by venous collateralization and return to good function, that is reversible of the process. The gradual obstruction, or so-called chronic renal vein thrombosis, can be complete or incomplete. We will always see expansion of the perirenal veins, that is a venous collateralization. And this is why the kidney will not enlarge or become atrophic, and why function will be preserved due to the effectiveness of the venous collateral circulation. So there will be little or no congestion, and structure and function will appear normal. Clinically, if there is a sudden occlusion of the renal vein, edema of the kidney will become manifested by severe lumbar pain. In children, particularly in infants, we may see an abdomen where the affected kidney will be palpable. Hematuria, proteinuria, and oliguria, and death from uremia will be the result of bilateral acute renal vein thrombosis. Most of the time, renal vein thrombosis, particularly in adults, is a gradual process. And as such, clinically, it will be silent. And this is because of the compensated phenomena as a result of the development of collateral circulation. However, proteinuria with or without hematuria may be observed, and the nephrotic syndrome may be a manifestation of gradual renal vein thrombosis. When the inferior vena cava is occluded as well as the renal veins, the patient may have edema of the lower extremities or lower part of the trunk, and these individuals are predisposed to pulmonary emboli. And one may see distended superficial collateral veins from the umbilicus all the way down to the pelvis. The prognosis of renal vein thrombosis will depend upon the location and extent of the venous occlusion, the rapidity of its development, the presence of other parenchymal disease, be that a tumor or of medical nephropathy, and depends also on the early diagnosis and the success of treatment. Pathologically, there may be no lesions of the kidney, and this occurs when there is a gradual occlusion and there is a collateral venous circulation. There may be hemorrhagic infarction, and this is seen particularly in children. A small contracted kidney is often associated with hypertension, and we may also see membranous thickening, that is glomerulonephritis, causing the syndrome of nephrosis, or the so-called nephrotic syndrome. Sometimes it is the membranous glomerulonephritis that precedes and not follows the renal vein thrombotic episode. Whenever we have a unilaterally enlarged, non-visualized kidney, we have to suspect certainly hydronephrosis. This will be the most common cause. We can suspect a hypernephroma. There can be diffuse inflammation of the kidney. We may have a patient with stones or without stones, but with xanthogranulomatous pyelonephritis or simple pyelonephritis. We have to consider the possibility of renal vein thrombosis, and also perirenal processes such as subcapsular hematoma. Urography may be absolutely normal. The kidneys can be normal in size. They can be enlarged, particularly in the acute phase of decompensated renal vein thrombosis due to the edema of the kidney, or eventually in chronic forms where there has been hemorrhagic infarction, the kidney will decrease in size. Again, the kidney is normal, enlarged, or small. The excretory function of the kidney depends on the mechanism of the renal vein thrombosis. We may see non-functioning kidney due to acute decompensated renal vein thrombosis, and this happens particularly in infants and children. The function of the kidney may be decreased, and we may see a delayed excretion with a poor visualization of a non-dilated pelvocalicial system, or the function may be absolutely normal. The calyces, renal pelvis, and ureters may be normal, or they may appear stretched or compressed due to the edema of the kidney, or there may be notching, that is indentation of the outline of the renal pelvis and or ureters due to the expanded peripelvic and periureteric veins. And we may see dilated perirenal veins, particularly on computed tomography and on nephrotomography. Regrouping the signs of renal vein thrombosis based on the frequency of observation and the urographic examination of the patient, we observe notching of the renal pelvis and or ureters, the presence of enlarged perirenal veins, and extrinsic pressure on the pelvocalicial system as the three most common urographic signs. Kidney function, normal, decrease, or absent, and kidney size, normal, enlarged, or small, are of less importance. The size and function of the kidney are less specific. And remember that the function can be normal, can be decreased, or can be absent. And the kidneys may be enlarged, may be normal in size, or may be small. This is a specimen to your left of a kidney with decompensated renal vein thrombosis. Note that the kidney is small. It has some irregularities in its contour, and there was no function from this kidney. The patient had hypertension, and the hypertension of renal origin is due to relative ischemia. If there is a complete ischemia, hypertension will not complicate the renal vein thrombosis. There must be a certain level of ischemia for the kidney to produce high levels of renin and angiotensin, etc., as a mechanism of renovascular hypertension. A coronal section of this small kidney shows hemorrhagic infarction in the lower pole. This is a young adult who presented with edema of the lower extremities and hematuria and proteinuria. A urographic examination shows that the kidneys are normal in size and they function normally and synchronously. Note, however, discrete notching along both ureters. An attempt to visualize the inferior vena cava upon injecting the right femoral vein showed extensive superficial and deep collateral circulation. The inferior vena cava was never opacified. We can also see opacification of the portal vein. This patient was a drug addict, and he ran out of veins in the upper extremities, was injecting himself in the lower extremities, and this led to thrombophlebitis. The phlebitis progressed into the iliac veins, and from there into the inferior vena cava. We saw at post complete occlusion of the inferior vena cava and of both renal veins. Another image of the venogram shows huge ascending lumbar veins, opacification of the portal vein, opacification of the vertebral venous plexus, and this patient, despite having total occlusion of the inferior vena cava and renal veins, the kidneys never change in size or function because the occlusion of the renal veins occurred slowly. So blood got in via the renal arteries and departed via anastomosis between the intrarenal veins and the perirenal venous circulation. And from there, it went into the portal system and into the systemic circulation. That's why this patient never had deterioration of renal function, despite that post-mortem revealing the presence of total obstruction of both renal veins. This patient is a 68-year-old man who had histologically proven membranous glomerulonephritis. Clinically, he suffered of the nephrotic syndrome. Suddenly, there was deterioration in renal function, and a repeated urogram revealed poor function of the two kidneys with very small pelvocalyceal systems, and there was a very discrete notching of the ureters. These findings were overlooked by the radiologists who interpreted this study. Repeat urographic examination with tomograms showed that the two ureters had notches due to dilated periureteric veins, as we shall discuss later. At another institution, a selective left renal arteriographic examination was interpreted as negative. However, note that following the parenchymal phase, we do not see opacification of the renal veins. Retrospectively, this should have been considered an indirect sign of renal vein thrombosis. A renal biopsy revealed all the signs of membranous glomerulonephritis. Electron microscopy revealed the dense material and the foot processes also described with membranous glomerulonephritis. In another patient, immunofluorescence was observed at the glomeruli, which is characteristic of the deposition of anti-gamma globulin proteins. In this patient, we did an inferior vena cavogram, and note that there is a very extensive filling defect at the entrance of the renal veins and occupying the hepatic segment of the inferior vena cava. Note the absence of streaming of unopacified blood that should be seen in a normal examination. This is pathognomonic of inferior vena cava obstruction with renal vein thrombosis. At surgery, the inferior vena cava was found to be filled with thrombi that extended from the renal veins into the inferior vena cava. The surgeon proceeded with a thrombectomy and also relieved the obstruction of the renal veins. Immediately after surgery, there is a massive proteinuria, and the patient gets worse. However, the renal function slowly returned to a baseline, and the consequence of renal vein thrombosis was deterioration of the abnormalities secondary to membranous glomerulonephritis. So a patient who has deterioration of renal function, one should look for associated renal vein thrombosis, which when present not only will deteriorate renal function, but will predispose the patient to pulmonary emboli. These are two patients with renal vein thrombosis associated with medical nephropathies. Both were inferior vena cavograms revealing the presence of extensive filling defects due to thrombi. And again, note the absence of the streaming effect that should be seen as unopacified blood from the renal veins enters the lateral walls of the inferior vena cava. This patient with amyloidosis shows the presence of thrombi in the renal veins, and on one side the thrombi protrude into the inferior vena cava. Causes of renal vein thrombosis due to medical nephropathies include glomerulonephritis, both the membranous and the membranoproliferative form of glomerulonephritis, renal sarcoidosis, amyloidosis, lupus nephritis, sickle cell anemia, and Goodpasture syndrome, which is the so-called pulmonary renal hemorrhagic syndrome. The pathogenesis of renal vein thrombosis in membranous glomerulonephritis is either a hypercoagulable state from increased platelets and fibrinogens, or from serum antithrombin, that is a decrease in the blood. It can be also due to hyperviscosity of the blood, to hemostasis, that is slow circulation, or to venous intimal injury. This is a young medical student who presented with hematuria. An intravenous urogram was obtained, and the clinical diagnosis was perhaps obstructive uropathy due to a renal stone. The IVP revealed extrinsic pressure on the left renal pelvis and discrete notches of the proximal left ureter. There was no evidence of a ureteral stone. We performed a selective left renal arteriogram, injecting the two renal arteries supplying the left kidney. In the venous phase, note that there is no visualization of the renal veins. Some collateral venous channels are noted caudal to the kidney, and observe that dilated veins are seen in the hilus of the left kidney and were the cause of the extrinsic compression of the inferior margin of the left renal pelvis. So this is an example of silent left renal vein thrombosis. This is a close-up of the left renal sinus in this patient with silent left renal vein thrombosis. Note the dilated peripelvic and periureteric veins, which explains the extrinsic pressure on the lower aspect of the left renal pelvis. Silent renal vein thrombosis may reveal nothing in the urinalysis or hematuria or proteinuria. And what is important is to recognize left or right renal vein thrombosis in patients who may not have any organic lesion of the excretory system of the kidneys, and the hematuria is coming from the renal parenchyma or from ruptured submucosal venules due to the congestion that exists around the renal pelvis or around the ureter. This is a child who presented with left flank pain and a palpable kidney. Note the poor visualization of a small left pelvocalyceal system and enlarged left kidney. A selective left renal arteriogram showed in the arterial phase some spreading of the arteries, which appeared slightly narrowed, but there was no focal mass in the left kidney. In the parenchymal phase, we see uniform opacification of the renal parenchyma of this enlarged left kidney, and there was no visualization of the renal veins when the study was prolonged. So this is another example of a left renal vein thrombosis manifested by lack of visualization of the left renal vein. 40% of all cases of renal vein thrombosis occur in infants. There is often a history of the 3Ds, which are dehydration, diarrhea, and maternal diabetes. 2/3 occur in the first 2 months of life, and nearly all occur under 2 years of life. Non-invasive imaging modalities for the diagnosis of renal vein thrombosis include sonography, computer tomography, isotopic examination of the kidneys, and magnetic resonance imaging. A baby had a palpable left kidney and proteinuria, as well as hematuria. Echographic examination of the left kidney revealed echogenic areas scattered through the kidney, which appeared enlarged, and also echoes coming from an enlarged left adrenal gland. Repeat echographic examination revealed the resolution of the adrenal hemorrhage and also a return to an almost normal size and echogenicity of the left kidney. This baby had an episode of left renal vein thrombosis, which was a reversible situation. An isotopic study of the kidneys revealed the photopenic area at the level of the left adrenal gland and decreased uptake at the level of the left kidney. Echographic examination of a child with renal vein thrombosis revealed in the affected kidney the hyperechoic interlobular streaks, which are very suggestive of this complication. Below, one can see the contralateral normal kidney with normal echogenicity in contrast with the speckled echogenicity of the affected kidney. In this other infant, and we're showing example of perinatal renal vein thrombosis, the right kidney in the sagittal projection shows loss of the corticomedullary differentiation and echogenicity in the form of striations, as well as enlargement of the kidney. All these are suggestive findings of renal vein thrombosis. There was a thrombus in the inferior vena cava, as indicated by the arrow. In this CT examination, one can see the enlarged right kidney with increased concentration of the contrast material, and note that there is enlargement of the right renal vein and of the inferior vena cava. A typical whiskering effect of the renal fascia is observed. In this left kidney, note a prolonged opacification, and that the left renal vein appears distended, and there is a large thrombus within it. Note in this patient with a carcinoma of the right kidney, which extended into the right renal vein, and there is therefore a mass within the right renal vein and inferior vena cava, the concordance in the imaging findings. To your left is the CT, and to your right the MRI. The MRI distinctly reveals tumor invasion of the inferior vena cava, which corresponds to the same findings in the CT examination. Similarly, in this next patient with a carcinoma of the right kidney, note the CT examination to your left, which shows an apparent mass in the hilus of the right kidney, which was suspected to represent a neoplastic extension or associated thrombosis of the right renal vein. However, the MR examination shows that the inferior vena cava and both renal veins are patent. So we can see, therefore, that the MR examination is more helpful to show patency of the veins, and that on CT examination, a mass at the level of the hilus not always represents dilated vein. And the MR examination, by showing the lumen of the vessel, is more specific than CT in the diagnosis of renal vein thrombosis. The angiographic findings in renal vein thrombosis can be divided in the arterial and in the venous phase of the study. The renal arteriogram may show a normal arterial phase, or the arteries may be stretched and or compressed. There may be flow retardation, and the renal veins may not be visualized or may reveal the presence of filling defects. We may see collateral veins surrounding the kidney, around the renal pelvis, in the retroperitoneum, and surrounding the ureters. The phlebographic examination may show the occluded renal vein and or the inferior vena cava with the pathognomonic sign, which are the filling defects in the renal vein and or in the inferior vena cava as well. There may be a patent inferior vena cava, but there will be lack of the negative defect caused by unopacified renal venous blood returning towards the inferior vena cava. And collateral veins are usually demonstrated. We're now going to show you in two cases the arteriographic findings in renal vein thrombosis. The first patient shows neovascularity just above the main right renal artery in topography of the right renal vein. The inferior vena cava study shows a large filling defect at the same site where the neovascularity was seen. And this is because the renal artery provides the vasa vasorum of the renal veins. And what we are seeing is the nourishment of tumor growing in the renal vein and in the inferior vena cava supplied by the right renal artery. In this next patient, we can see the neovascularity above the right renal artery. Note also neovascularity in the right kidney. The patient had a right renal cell carcinoma that occluded the renal vein and extended into the inferior vena cava. And the inferior vena cavogram confirms the diagnosis of a tumor growing into the cava, which was supplied by the expanded vasa vasorum of the renal vein and the inferior vena cava, which is supplied by the renal artery. This is a cast corrosion preparation where a red plastic was injected in the renal artery and blue in the vein. Note that in the surface and inside the renal vein we see red. This is because the vasa vasorum of the renal vein was supplying the tumor that involved the right renal vein in this patient. And the penetration of arterial supply into the lumen of the veins is what one sees in the arteriographic examination of patients that have neoplastic occlusion of the veins. In order to document the presence of renal vein thrombosis, we may start with an inferior vena cavogram. And in this patient, note the large filling defect at the entrance of the right renal vein. This is a case of a tumor of the right kidney involving partially the inferior vena cava. This is a patient that shows obstruction of intrarenal veins from a transitional cell carcinoma of the left kidney. The selective renal arteriogram, which are the frames to your left and in the middle, reveal very minimal neovascularity and a filling defect in the mid portion of the outer left kidney. The third frame reveals a selective renal arterio. The third frame shows a selective left renal venogram. Note the obliteration of many intrarenal venules and irregular vessels at the site of the tumor. This is a selective left renal phlebogram of the same patient. Note the very extensive area of the left kidney that could not be suspected on the arteriogram. So the phlebogram is more sensitive for space-occupying masses that are small and do not elicit significant neovascularity than the arteriogram. One of the reasons for failure of a transplanted kidney is renal vein thrombosis. And in this patient, note the narrowing at the junction of the renal vein with the common iliac vein. There was no occlusion of the vein, but significant narrowing interfered with the venous drainage of this transplanted kidney. The pancreas is supplied by branches of the celiac trunk and of the superior mesenteric arteries. The veins of the pancreas drain primarily into the portal vein. In this very complex cast corrosion preparation, one can see the duodenum casted in white and the head, body, and tail of the pancreas with the arterial supply and its veins. Note that we have the spleen above the upper pole of the left kidney. And we can see through the tail of the pancreas the left adrenal gland. Note that we have casted the veins of the adrenal gland and of the left kidney in blue. We can also see in blue the termination of the superior mesenteric vein. Note that the splenic artery runs along the upper border of the body and tail, and just caudal to it we can see the splenic vein. We can see the proximity of the left renal vein to the body and tail of the pancreas. And we can also see, as later will be better described, extensive venous communications between the body tail of the pancreas with the upper pole of the left kidney and with the left adrenal gland. This is another cast corrosion preparation showing the venous connections of the pancreas to adjacent structures. For example, the red arrowhead shows a connection with the upper pole of the spleen. The orange arrowhead indicates the splenic vein. Note that we have slightly oblique the specimen in order to show the left renal vein, above it the adrenal gland, and venous connections are seen between the adrenal gland and the body and tail of the pancreas. We have ligated the renal vein, so we only see its proximal portion, which receives the left gonadal vein. This is a close-up of a cast corrosion preparation showing the proximity of the splenic vein to the renal vein. Also note that there are venous connections between the tail of the pancreas, the upper pole of the left kidney, and the left adrenal gland. This is a close-up of the tail of the pancreas. I stained in white the intravenous connections between the upper pole of the left kidney, the left adrenal gland, and the pancreatic veins. Large venous structures are seen between these organs. Another close-up of a cast corrosion preparation. In white are the veins that connect the tail of the pancreas with the upper pole of the left kidney and with the spleen. These are large venous structures that often are severed when a nephrectomy is performed and there is a tumor in the upper pole of the left kidney. Not only the normal veins can be transected, but because of the hypervascularity of a cancer of the upper pole of the left kidney, large venous channels are noted often surrounding the cancer. These are veins that are impossible to separate at the time of surgery from the tail of the pancreas and from the spleen. It is not uncommon to see left nephrectomies accompanied by selective splenectomy and sometimes even by resections of the tail of the pancreas because of the bleeding caused by the resection of these venous channels. It is wise to embolize tumors of the upper pole of the left kidney to decrease these perirenal venous channels and use less blood in the form of a transfusion when a selective left nephrectomy is carried out. We did this cadaver study injecting barium in situ into the portal system. Note the splenic vein that receives veins of the tail of the pancreas, which are perpendicular to the undersurface of the splenic vein. Also note the entrance of the inferior mesenteric vein almost at the angle of the splenic vein with the superior mesenteric vein. The superior mesenteric vein is the large channel seen to the right of the inferior mesenteric vein. Cephalad from the splenic vein and almost at the junction of the splenic vein and the portal vein is a very enlarged coronary vein. This patient had hepatofugal circulation due to portal hypertension secondary to liver cirrhosis. Note that from the tail of the pancreas we see two venous channels that are connected to the left renal vein. So we can demonstrate, therefore, in anatomical specimens, veins of the tail of the pancreas that can connect with the left renal vein. In another cadaver, we selectively casted the veins of the pancreas. The ventral and dorsal view of the body, head, and tail of the pancreas are illustrated. Note the large portal vein receiving the splenic and mesenteric veins. Note that the veins of the head of the pancreas drain into the portal vein and also some into the superior mesenteric vein. Note also that running along the upper edge of the body and tail is the splenic vein. We have not included in the specimen the spleen or the left kidney. The veins of the body and tail drain towards the splenic vein preferentially. So if one is to do sampling of blood from the body and tail, one would have to catheterize the splenic vein and enter some of these small veins, or simply sample blood from the splenic vein distal, proximal, or in its middle third. This is an axial view of the head and body of the pancreas. Note the portal vein, and note also that dorsal to the pancreas, we see the terminal part of the left renal vein, which terminates in the inferior vena cava. And just behind the left renal vein, we see the aorta. This is to show the proximity of the left renal vein to the pancreas. This is a sagittal section of another cadaver taken to the left of the midline. The patient's anterior portion is to your left. The dorsal part of the patient is to your right. Note the large adrenal gland just behind the tail of the pancreas. And note that running along the upper border of the tail of the pancreas is the splenic vein. And note that just below the tail of the pancreas is the left renal vein. What we have tried to demonstrate is the extensive venous connections of the pancreas with organs such as the spleen, left adrenal gland, and left kidney. Also to emphasize the proximity of the left renal vein to the body and tail of the pancreas. This explains how pancreatic disorders, be that inflammatory, pseudocyst, or neoplasias, can involve the left renal vein. And because of the proximity of the tail of the pancreas to the upper pole of the kidney, one may see masses in the kidney that are a reflection of a pancreatic disorder, be that pancreatitis, pseudocyst of the pancreas, or tumors. This is a nephrotomogram of a patient that had a pseudocyst of the tail of the pancreas. Note that the upper pole of the left kidney is enlarged. And also note that it is somewhat hypodense. At first glance, a mass of the upper pole of the left kidney was suspected. However, this mass proved to be invasion of the kidney from the tail of the pancreas, which had a pseudocyst. Signs of left renal vein thrombosis, particularly notching along the left ureter, are demonstrated in these next cases. This first patient is a patient with acute pancreatitis. Note that there is very fine indentation, that is notches, along the left and right wall of the ureter, and this finding corresponds to collateral periureteric veins secondary to left renal vein thrombosis. And as we have described previously, often a gradual obstruction of the left renal vein does not produce changes in size or function of the left kidney. So we should therefore look for collateral circulation to make the diagnosis of renal vein thrombosis. This patient had reversible notching, and upon resolution of the pancreatitis, repeat the urography revealed a normal left ureter. So renal vein thrombosis may be a reversible process. This patient had a pseudocyst of the tail of the pancreas. The urographic examination only reveals some notching along the proximal left ureter and poor visualization of the calyceal system. And the notching was really the only sign of renal vein thrombosis, which in this case was due to compression or to involvement of the left renal vein from the pancreatic pseudocyst. In this patient with chronic pancreatitis, we can see extensive calcification of the pancreas and non-visualization of the left pelvocalyceal system. And the non-visualization was the consequence of obstruction of the left renal vein. In this case, a decompensated left renal vein thrombosis. This is the left urinary tract of a patient with a carcinoma of the tail of the pancreas. Note the notching of the proximal left ureter, but observe that there is no abnormality as far as the kidney size or function. The venous phase of a celiac angiogram reveals total obstruction of the splenic vein, as indicated by the two arrows, just above the projection of the left renal pelvis. Note the persistent notching of the proximal left ureter. Note also encasement of the proximal portion of the portal vein. This patient had a non-resectable cancer of the pancreas. Another patient with a carcinoma of the tail of the pancreas revealed lateral displacement of the proximal left ureter. In this case, there was no notching, only a mass effect. What is the differential diagnosis? A tumor of the retroperitoneum that could be in the nodes of the high aortic chain, such as lymphoma or metastatic disease. This could have been a retroperitoneal sarcoma or even a tumor of the kidney extending medially. In this case, it was the tumor of the tail of the pancreas that displaced the proximal left ureter. This is a selective left renal venogram of the same patient with a carcinoma of the tail of the pancreas. Note that there is encasement of the left renal vein. Another sign that we could have expected would be notching of the ureter, and that may happen if the patient lives long enough to cause distension of the perirenal venous plexus. Note that there is a large capsular vein coming off the upper pole of the left kidney. This is a specimen of a cancer of the tail of the pancreas. Note that there is the complete obstruction of the splenic vein, and also note that there is a mass below the splenic vein, and this is a portion of the tumor that can invade or compress the left renal vein or even the left kidney. The last 6 slides are of a very interesting patient, a 69-year-old woman who was admitted because of aching pains throughout her body that were more severe in the back and in the right lower extremity. The physical examination revealed a slight splenomegaly. The patient had extensive workup by 2 gastroenterologists and a psychiatrist, and the working diagnosis was that she was a psychoneurotic patient. Part of a workup was an intravenous urographic examination. Note that there is a slight enlargement of the spleen, and note that there is a discrete density medial to the left kidney, just above the left renal pelvis. A nephrotomogram of the upper urinary tract shows a discrete nodule that is medial to the hilus of the left kidney. What is the differential diagnosis? Adenopathy might be a possibility. Another one that we might see a buccal vessel in this region. It could have been also a small tumor. This is the venous face of an abdominal aortogram. The spleen appeared slightly enlarged. In the hilus of the left kidney, we can see dilated veins. There was no visualization of the left renal vein. These dilated veins are the result of obstruction of the left renal vein with collateral circulation. Selective left renal arteriogram showed in the arterial face normal arteries and normal renal parenchyma. In the photograph to your right is the venous face of this selective examination. Note the buccal collateral venous channel indicated by the arrow, which represents a dilated juxta-renal vein and expression of collateral venous circulation. The patient had total left renal vein thrombosis. A selective left splenic arteriogram shows encasement of the proximal splenic artery, as indicated by the arrow. The bottom image is the venous face of this selective splenic arteriogram. Note that there is no visualization of the splenic vein, that the spleen is slightly enlarged, and we can see a large left gastroepiploic vein, and some veins that are observed paralleling the splenic vein. They reconstitute and opacify the portal vein indicated by P, indicating that there was a complete obstruction of the splenic vein and antegrade periportal collaterals that filled in an antegrade fashion the portal vein. So in the presence of a splenic vein obstruction of the left renal vein, one has to think in pathology of the pancreas. At surgery, this lady had an extensive cancer of the pancreas, which was not clinically suspected. We are omitting the CT examination that revealed a non-resectable tumor of the pancreas. Renal hilar fat connects with the perirenal fat, and the purpose of it is to probably allow the renal pelvis to distend as urine is produced and stored in the pelvocalyceal system. Some patients who have extrarenal pelvis do not have prominence of the hilar fat. As a matter of fact, if we see excessive fat within the kidney of a patient with extrarenal pelvis, we must suspect a pathological condition. Excessive fat in the renal sinus may be an anatomic variation, but also may be seen with inflammatory and other processes of the kidney. This is a nephrotomogram of a normal patient who has abundance of peripelvic fat at the level of the renal sinus. This is a perfectly normal finding. On a cast corrosion of the left kidney, we photographed the hilar portion and note the space between the renal pelvis and ventral to it, the branches of the renal artery, and ventral to the artery, the renal vein. In other words, this patient had an intrarenal pelvis with normal fat surrounding it. This is a left kidney of a 20-year-old woman who had lost weight considerably and presented with hematuria. Note that there is a filling defect in the upper portion of the left renal pelvis. But also note that we do not see fat surrounding the renal pelvis. A nephrotomogram of the left kidney shows a discrete filling defect or a lucency in topography of the left renal pelvis at the junction of the left renal pelvis with the infundibulum of the upper calyx. Differential diagnosis would have to include a radiolucent stone, a benign or a malignant tumor. A selected left renal arteriogram shows that there is a branch of the left renal artery that indents the upper portion of the left renal pelvis. So therefore the filling defect was due to extrinsic compression from a normal vascular structure, in this case a branch of the left renal artery. What has happened in this lady was that the loss of weight and the loss of fat at the level of the left kidney allowed the proximity of the peripelvic vessels to the renal pelvis. Her hematuria was due to a cystitis. So one differential diagnosis to entertain in individuals who have lost weight or have very little renal sinus fat in the differential diagnosis of a filling defect at the level of the renal pelvis or infundibuli or calyces may be the absence of fat and indentation of these structures by a branch of the renal artery or of a renal vein. Excessive fat due to a pathological condition is noted in this first case, who had a cyst in the upper pole of the kidney and a cancer in the lower pole. This other patient with abundance of fat had bilateral renal papillary necrosis. And our last case is excessive fat in a patient who had angiomyolipoma. So fat is a normal finding or can be abnormal in the presence of benign and malignant conditions of the kidney.